to think through. The case from yesterday was a young woman who was having recurrent episodes of abdominal pain, particularly after eating, and particularly after eating fatty foods. The pain was primarily in the right upper quadrant, and then also over time started to be associated with other systemic symptoms like a rash and itchiness, as well as some respiratory symptoms like wheezing, coughing, and shortness of breath. And so what the case ended up, sort of the way that it ended up unfolding was kind of moving through the traditional evaluation of abdominal pain, obtaining basic labs, unremarkable other than a white count. Imaging was stone cold negative. We started to sort of go through the exercise of image negative abdominal pain, particularly in somebody who was having right upper quadrant abdominal pain. And we got to ask ourselves, how good are some of the imaging findings that we traditionally use to evaluate somebody with right upper quadrant abdominal pain? A CT is an excellent test for detecting overt or sometimes somewhat subtle intra-abdominal pathology, but we got to explore some of the types of diseases in which the CT scan can fail us, whether that's infiltrative disease of the liver or problems with the hepatobiliary tree. Sometimes the CT scan can miss us. And so we talked about an MRCP as a next step diagnostic, as well as an ERCP as something that can give us diagnostic and therapeutic if we have biliary pathology, which we were all sort of leaning towards in this woman who had right upper quadrant pain and itchiness, which we were chalking up to potentially cholestasis. But the labs and the imaging were totally unrevealing. And we did what all clinicians oftentimes do when you come to a brick wall in a case, is we went back to the history. And we started to examine not the abdominal pain, but actually everything other than the abdominal pain. How can we start to link abdominal pain, rash, and itchiness, and respiratory symptoms? And we started to explore the fact that those are all symptoms that you can see in IgE-mediated or histamine-mediated reactions, right? If we think about anaphylaxis, it's a syndrome characterized by multi-system involvement. The skin, the respiratory system, the gastrointestinal tract, and also oftentimes the cardiovascular system when there is florid shock involved. And we started to ask ourselves, gosh, maybe the skin plus the lungs plus the abdomen is not a sign of a pure intra-abdominal pathology, but of a systemic pathology, potentially something related to IgE or histaminergic diseases. And then we looked at what actual foods were triggering the patient's reaction. It was primarily after fatty foods, which again was a trigger for biliary pathology up front, but then evolved to be a trigger for thinking about, can someone have a meat allergy? And the answer to that question is yes, people can develop or have meat allergies. There are a number of flavors of meat allergies that can move through the various phases of life. In infancy, people can have young children can have some allergy to animal proteins as they are introduced into their diet. Whereas over time, people can develop an IgE-mediated allergy to meat, or there is the fascinating syndrome of alpha-gal, or the alpha-gal syndrome, which is an acquired meat allergy that develops after exposure and sensitization to alpha-gal, usually via a tick bite. And so we basically found that when this young woman cut all meats out of her diet, she did okay, but had very limited nutritional intake. But then she had Jell-O one day, and that then worsened her symptoms. And you might ask, how does Jell-O align with a meat allergy? And the reason is that gelatin is an animal product that has a high amount of that alpha-gal compound in it. And so that ended up being the key that unlocked the case, which again, the final diagnosis ended up being this alpha-gal syndrome, which is a acquired meat allergy that comes after exposure to a tick bite. The alpha-gal compound is present on many animal skin surfaces. And when the tick bites us, it puts and inoculates a small amount of that compound into our skin. Your body develops an immune response to it. And over time, with sequential exposures to alpha-gal, which is present in many red meat products like beef, pork, and lamb, as well as gelatin, your body can mount an increasingly escalating immune response to it. So think about alpha-gal when you have basically postprandial abdominal disease, particularly after fatty foods in somebody who has risk factors for a tick bite. It is a rare diagnosis, but one of those diagnoses that we have to go and hunt for in order to make a definitive diagnosis. All right. I am now out of breath, so I'm going to take some time to catch my breath, and I will come to you, Vale and Rafa, to see if there's anybody who has volunteered to discuss or to present a case today as I scan through the chat.
Yeah, we have Jewel who's going to present the case, and Colleen also volunteered to discuss with us.
Amazing. Colleen, thank you so much for volunteering to discuss. I would love if you would be willing to unmute yourself and introduce yourself as we look for one more discussant to join Colleen today.
Hi, thanks, Jack. Hi, everybody. I'm Colleen. I am in my 4th year of medical school at UCSF in San Francisco. Working on my residency applications today.
Exciting time. Exciting time. Colleen, thank you so much for being here. It's great to see you. And then I see, looks like Franco. I apologize if I mispresented it, but please do it looks like you put one foot into the lukewarm seat. Please join us and put the other foot into the lukewarm seat and come and discuss with us today.
Hi, everyone. I'm Franco. It works both ways, Franco or the other one. It's okay, no worries. So I have been presenting and discussing quite a bit as Colleen lately, so I'm glad to join here. I recommend everyone to do it. I haven't met you yet, but I think this is going to be great. And I'm from Peru. I am also applying to internal medicine this year. So I have been working with my personal statement, as Colleen said.
Yeah. It's a busy time. I am really touched that all of you, amidst everything else you have going on, have chosen to spend your time with all of us today for this hour. I'm excited. I hope that we'll make it a great case discussion. And then why don't we go ahead and turn it over to Drew to introduce yourself and take us away with the case here. Let's see, Colleen, do you mind? I will take each aliquot with the both of you, and then maybe actually I will let Colleen and Franco. I will let you decide amongst yourselves who takes the first aliquot here. And then Drew, it's great to see you.
Great seeing you yesterday, Jack. And for those of you who have not met me or who have not seen me in a while, hi everyone. I'm Drew. I am a PGY1 in Med Peds at Western Michigan University School of Medicine. And this is a case of a patient who I saw. Well, it'll become clear as I present the case, but this one is a little bit of a doozy, as most of my cases seem to have been. Although it's a little bit more bread and butter than the couple of cases that I've presented the last couple of times. So
it is getting close to dinner time, so that sounds like some bread and butter sounds good. I'm with you, Colleen. No doozies allowed. I want clear, simple, straightforward diagnoses.
All right. So the chief concern for this patient, I guess has everyone decided like who's going to go first or who's going to how you guys are going to split up the aliquots? Or
I'm totally fine, whatever it is. So Colleen, you want to go first?
Go first, sure.
Okay. Let's do it.
Great. So chief concern for this patient is knee pain. I'm going to stop there for now and give you the context that this patient first presented in the outpatient world. So I want to hear what you guys think so far as to how you would work up knee pain, for someone who just comes in the outpatient clinic.
Okay, so if I'm thinking about knee pain, I think kind of the context of the knee pain and also sort of the demographics of the patient are kind of the first things that I would think about if I was kind of just seeing knee pain on, as a chief complaint on the computer. So I guess in thinking about kind of, chronic causes of knee pain, the most common thing, depending on the age of the patient, is going to be something like osteoarthritis causing knee pain. Can also think about more inflammatory arthritis is a cause of knee pain. I also wonder, you know, if this is something that is more of a acute onset knee pain, whether or not there's been an injury. I also think about infections that can have like a pretty quick onset, and definitely like kind of keeping my eyes out for physical exam findings, like, is this joint, you know, is there a large effusion in the joint, or any kind of like deformities around it. I guess lots of big buckets. This is like a very very open chief complaint that I'm thinking about here.
I love it, Colleen. I think your analysis of sort of what is the lens that we are going to be viewing this knee pain through was fantastically well said. Knee pain, I think there are many things in the world of clinical reasoning where it sort of feels like we have something to center on, but the thing that we center on just opens up an enormous number of doors further down the case. And I think knee pain is exactly one of those. And so we have to decide, are we going to look at this knee pain through the lens of systemic inflammation and focal joint inflammation, or are we going to be looking at this knee pain through the lens of high amounts of physical activity or recent trauma? Are we going to be looking at this knee pain through chronic overuse? And so the sort of, right, if we think about what are the glasses that we're going to be using to examine this knee pain, it has less to do with the knee pain itself, and actually far more due to the co-conspirators that are coming alongside the knee pain here. So is it are the co-conspirators fever, joint swelling, and joint effusion? Are the co-conspirators morning stiffness, or are the co-conspirators things like hyperactivity and overuse? Because those are the types of things that can give us sort of the three big buckets that we can think about for knee pain. One is just a broad general category of a musculoskeletal complaint, whether it's a meniscus tear, whether it's patellofemoral pain syndrome, or something related to using the knee. So one, MSK. Two would be OA, as Colleen mentioned, a very common cause of knee pain in the outpatient setting, with some of the classic history and exam findings that we may see unfold. Or are we dealing with a non-osteoarthritis, right? Is it an infectious arthritis, an inflammatory arthritis, or a crystalline-induced arthritis? And then there's everything else. There's a whole other host of things that can ultimately cause knee pain, but those categories, MSK, OA, and another inflammatory arthritis, are usually the buckets that I think about starting with. And the ways that we can make progress is, one, by getting a sense of how long this has been going on. Tempo is queen, as we have talked about before, and also getting a sense of what the knee looks like. If the knee is red, hot, swollen, and angry, it's a whole different journey that we get to go down compared to if the knee is painful with activity but otherwise looks okay. So I think those are the types of things that I'm going to be looking for up front. But I think the first thing is we just need to get more information about who the co-conspirators alongside the knee pain are in this case.
Co-conspirators indeed, because let's just say that this case is a little bit more complicated than it initially looks. So let me give you a little bit more of the HPI, and then I'll also fill in the southwest corner as well. So this is a 70-year-old gentleman who is coming into the clinic. 5 days prior, he was seen in the emergency department for acute on chronic bilateral knee pain and instability. He was in his usual state of health until the day prior to him going to the ED, when he was unable to rise from his chair for about 18 hours. So at the ED, he was given pain relief, and subsequently was able to ambulate with a walker, and then he was ultimately discharged. Since then, the patient has had multiple falls within the last couple of days. He's had weakness in his right hand and worsening knee pain. And for this patient actually had to have emergency medical services actually come to take him into this outpatient clinic visit today. And he was, just to note in the social history that this patient lives with his wife and his wife was unable to lift him. And just in terms of other symptoms, the wife also notes that the patient has had tremors in his right hand and more mumbled speech. In terms of just other symptoms, the patient has also had leg swelling, constipation, joint swelling, dizziness, and just in general, like much lower level of activity. In terms of past history, at the ED, he was diagnosed with osteoarthritis. But prior to that, this patient had not seen a doctor within the last 10 years. In terms of medications, the only things that he was on were what he was given at the emergency department, which were gabapentin, lidocaine, patches. And then he was also taking Tylenol and ibuprofen to try and relieve the pain. In terms of family history, mom had breast cancer, diabetes, and Parkinson's disease. Father and brother had kidney disease and diabetes. Brothers also had a history of heart disease and stroke. And he also has a daughter who has diabetes. He does not, in terms of social history, as I said, he lives at home with his wife. He is retired. In terms of health-related behaviors, he does not smoke, does not drink, and does not use any other drugs. And no allergies known. And I am going to leave it there for now.
Well, right now we're presenting with a man that has a chronic issue regarding the osteoarthritis, and there is something else that is going on. There are some kind of neurologic things that can definitely need to be taken in order to think about his diagnosis. I think that there is an issue about gabapentin that there are high doses of gabapentin, or if there is some kind of renal problem, the gabapentin can cause some sort of toxicity that could fit with some of these symptoms, like the mumbles in the speech, the tremors. But the only thing that is kind of making a little noise for me is the joint swelling. I don't know if this is a joint swelling that have been there for a while, if it is recent. Because if it is an acute swelling, we could possibly also be looking for a septic arthritis arising for some place there, and he's also maybe developing an infection there, and those the neurologic symptoms could be point to a sepsis kind of a picture over there. Other than that, I think we're pretty much, I think the knee problem and the knee pain is something that we are going to put in a second spot right now to look forward the neurologic symptoms. I don't think I could point to someone else beside the infectious and the medication over there.
Marco, I just want to call out what you did there when you said we're going to have to put the knee pain in the second spot here to focus on the neurologic symptoms. I think that is a phenomenal reasoning point to share here. Because while we have knee pain at this point in the case so far, the challenge in evaluating the knee pain is that we still don't yet have the data that we need to formally evaluate this, right? We know that there is some joint swelling, but is it the only joint of the knee that is swelling, or are we dealing with multiple joints that are swollen? Do we see a knee effusion? Is the knee red and warm? Because right now we have knee pain, But then we also have lots of other symptoms that we cannot explain by that list of diagnoses that Colleen gave us as an initial approach to knee pain alone. So as you said, the neurologic symptoms are things that we have to at least try to think about explaining. And I'm curious if I can kick the mic back to you. I'm curious if you're willing to share anything in terms of how you're organizing or at least thinking through some of these neurologic symptoms so far.
Yeah, I think about the neurologic symptoms, well, multiple falls can fit into 2 points. Or he's old guy there with some chronic pain, so that could be part of the neurological symptoms, or could be only a neuromuscular issue. So I'm kind of trying to fit the multiple falls as an acute neurological process, plus the weakness in the right hand. Although the weakness in the right hand can also have been some sort of, if there is swelling in the right hand and if there is some nerve compression over there, can also explain a peripheral process of weakness.
Yeah.
But it has multiple fall, weakness, and tremors, although they are also pointed in the right hand. So I think this the only thing that is kind of localizing over there besides the knee. So the only thing that could put the balance over the neurologic things would be the multiple falls, if we put a little weight on that symptom. That's the way I'm thinking right now.
I think that was absolutely brilliant. And again, just a phenomenal thought process of saying, how do we take all of these disparate findings and try to start to link them together at least a little bit? We've talked about falls before on VMR, and falls are an incredibly difficult problem to work through, because everything that we use to stand, if one of those things breaks down, we fall, right? Fall is just the inverse of standing. And so if we think about all the things we need to stand, we need muscles, we need vision, or I should say we need muscles, vision can help, cortical function can help, the peripheral nervous system helps us, a sense of balance from the cerebellum helps us, perfusing our brain from the cardiovascular system helps us, right? So there's so many things that can go into leading someone to fall. But you highlighted that this sort of right hand weakness starts to point us potentially towards the neuraxis or the neurologic axis as an etiology of the falls. And then we have this other finding here, which is the changes in voice. And it sounds like difficulty speaking or potentially dysarthria. I'm not sure if we're dealing with slowing speech or difficulty speaking, but if we were just saying that this gentleman has speech problems, we then start to ask ourselves, well, how can we start to link right hand weakness and speech problems, right? Is it something that's affecting multiple components of the neurologic system, right? Are we dealing with a multifocal neurologic process? Usually that's going to be something that is immune mediated more often, or are we dealing with something that's hitting a very particular part of the brain or multiple parts of the central nervous system that's impacting both of those, right? Are we dealing with a brainstem process that's giving us dysarthria, or is it a cortical process that's giving us dysarthria? If we're going to get a cortical process, or I should say, if we're going to get hand weakness and dysarthria, it probably has to be something higher up in the cortex. But I'm going to sort of remix this whole dysarthria thing right now and say that maybe it's actually not a neurologic problem that's giving us dysarthria. Maybe it's something related to the patient's ability to, maybe it's potentially something related to the structures that go into speaking. For example, if somebody has tongue pathology, right? If the tongue is big and swollen and bulky, like we may see in a disease like amyloidosis, we can have difficulty talking and we can see changes in speech. You may be saying, Jack, why the heck are you bringing up a diagnosis like amyloidosis here right now? And the reason is that if we zoom out from the neurologic symptoms alone, we're now dealing with a multi-system disorder, right? We have signs of joint involvement. We have signs of potentially neurologic problems. We have signs of those neurologic problems being maybe in the peripheral nervous system and maybe in the central nervous system. We also have this tremor that we have developed as well. So we're seeing things cross multiple systems if indeed this knee pain is musculoskeletal in nature. And so we have to start thinking about multi-system disorders, which could be something like a disseminated infection. It could be something like a perineoplastic process or a malignancy related disease. or we start to think about the sort of systemic autoimmune diseases like collagen vascular disease, although this gentleman is quite old to be developing something like lupus or a connective tissue disease, an underlying vasculitis, which we know can infect multiple organ systems, or something like amyloidosis, which is also notorious for hitting multiple different body systems at once. And so what can we say so far? We're seeing mounting evidence of a multi-system process developing, and a multi-system process that seems to potentially involve the neurologic axis. I see Colleen mentioning in the chat too that Parkinson's disease is coming into play. And I think that that is an absolutely brilliant point to add, because the knee pain could be a part of the patient's syndrome, but plenty of people who are 70 years old also have painful knees, and that could just be a distractor. And maybe our focus deserves to be on the neurologic axis. All I can say so far is two things. One, Drew was right, this is a doozy. And then the second thing that I can say is that I think we need to better understand what bodily systems this disease is affecting. Is it a singular system process or a multi-system process? And that will help us start to focus our differential a little bit further and make some progress going forward here in this case.
All right. So now we'll go to the physical exam, and hopefully this will give a little bit more clarity, or maybe not. So vitals, and by this time, the team at the outpatient clinic was so concerned about this patient that they immediately, they had done a physical exam already in the office, but they believed that this patient needed further evaluation. So he's now inpatient. So vitals, temperature 98.1 Fahrenheit, heart rate of 72, blood pressure of 143/86, rest rate of 20. And this patient is satting 96% on room air. And let me just see if there's a BMI. No, there's no BMI. All right. While the patient was inpatient, he had multiple other things that he mentioned as well, including difficulty with urination, nocturia, incomplete bladder emptying, and had also endorsed a remote history of gout as well. But generally, the patient was resting comfortably and in the bed in no acute distress. His HENT exam, the most notable things were hearing loss in the left ear, and several teeth that were missing from the lower jaw, but otherwise no conjunctival icterus. The pupils were equal, round, reactive to light and accommodation, and his oral mucosa were moist, and the pharynx was without exudates. His neck was supple. There was no jugular venous distension, no thyromegaly. Cardiovascular exam, normal rate, regular rhythm, no murmurs or gallops. Respiratory exam, clear, but the breath sounds were a bit distant due to body habitus. GI, obese, but normal bowel sounds, soft and non-tender with no hepatosplenomegaly or any masses. MSK exam, painful active and passive range of motion, especially in flexion in both knees, and both knees had mild effusion. And by this time, they had noted that the patient had mild erythema over his left knee with some scratch marks. And the patient had attributed these changes to one of his falls. On his neuro exam, he was alert and coherent. Speech was normal. His cranial nerves 2 through 12 were intact, and the patient was following all commands. Sensation was impaired to fine touch in the bilateral lower extremities all the way up to the knees. And on motor strength testing, he was 4 out of 5 in the left upper and left lower, and 3 out of 5 in the right upper and right lower. His deep tendon reflexes were all 2+. There were no resting tremors. His coordination was, actually, let me make sure that I have this right real quick. Moderate difficulty with finger to nose in the right upper extremity. His left upper extremity was normal. And they were unable to do a gait exam or test his lower extremity coordination due to the fact that he just was not able to stand. And he also had pronator drift on the right side, mild pronator drift. So I will leave that there for now. The next aliquot will be labs, and then there will be one more aliquot with the final test that will reveal the final diagnosis.
Okay. Thanks for such a rich physical exam. That was very comprehensive. Okay, so I guess in thinking about this physical exam, you know, in the last aliquot, we were kind of talking about neurologic findings versus, you know, this being a problem that's just isolated to the knee. And I think one of the things I'm taking away from this physical exam is that there is definitely, you know, so much going on with the nervous system that absolutely could not be explained by just like a process isolated to the knee. So I think that at this point, we really do have to zoom out and think like very broadly about the nervous system. I think, you know, the fact that this guy's knee is a little bit, you know, red and has a small fusion could be consistent with osteoarthritis. But at this point, I'm kind of going to take that and just put that aside and really, like Franco said, kind of zoom out and think about neurologic processes as kind of a separate pathology at this point. One of the things that I'm noting, you know, this aliquot that you added about there being, you know, dizziness, urinary symptoms, and constipation is kind of making me wonder, you know, is there a problem that is like kind of specifically affecting the parasympathetic nervous system? Just that kind of constellation of symptoms sort of jumps out at me. And then, you know, zooming more into his physical exam, sorry, let me just look at this again. So this patient has, I guess, both sensory and motor defects in his lower extremities. And then, was that, strength exam? His sensation was not impaired in his hands.
He did have some numbness and tingling in his hands, but no, there was no impairment of sensation.
Okay.
It was only impaired in his lower extremities.
Okay. And so I guess for his, you know, thinking about his motor exam in terms of kind of trying to localize this to like upper motor neuron versus lower motor neuron, it sounds like he has like something that kind of sounds like rigidity in his lower extremities, in addition to weakness, plus pronator drift in his right hand, which is kind of reading as more of an upper motor neuron process to me. So it's kind of localizing things more to the brain or spinal cord rather than the peripheral nervous system. I think I have to say my knowledge of neurology has kind of faded away in my time since that rotation. So maybe I can have Jack jump in and help me out with some of this stuff.
Well, and I'm going to be honest with you, I have no idea what's going on either. Just in full transparency, I think that this is a really challenging neurologic exam for me to localize for a couple of reasons. One is that I'm not that good at neurology. And the second reason is that it's really hard to put these pieces together, right? We have symmetric sensory findings, asymmetric motor findings. We have findings suggestive of a sort of length-dependent peripheral neuropathy, but then we also have cortical findings in the presence of this pronator drift. And so I think the thing that I'm really struggling with is how much of this is a bystander, right? Many people can have, for example, a length-dependent peripheral neuropathy. We see that this gentleman takes gabapentin, so maybe he's had a neuropathy for quite some time, and the cortical findings are new, or maybe all of it has come together, right? And so I am with you in saying that the findings on this neurologic exam are tough to pin down on one specific process, because that process would have to span multiple parts of the nervous system in addition to impacting those parts of the nervous system at different severities. But then it could also be explained by multiple processes happening at once. The reason I'm saying that is, for example, if we look at just the sensory finding here, sensation was impaired up to the knees bilaterally. That is a very classic thing that we will see in people who have a length-dependent symmetric sensory polyneuropathy, something from diabetes, alcohol use, hypothyroidism, toxin-induced neuropathy, right? This is a very common finding. We usually see that in isolation. We don't usually see that in association with asymmetric weakness, right? And so the question is are we dealing with a motor and sensory neuropathic process? That would be a bit peculiar because the motor involvement has started to impact the upper extremities. Most length-dependent neuropathic processes will cross the knee before they hit the fingers. That's why we call it a stocking glove distribution. The one caveat to that is that demyelinating neuropathies can sometimes jump that, but like diabetes, alcohol use, these sort of classic sensory neuropathies, and even many demyelinating neuropathies will impact the hands once they cross the knee. But in this case, which seems like we have motor in the upper extremities, but no real motor in the uppers and lowers, but sensory only in the lower. And so are there actually two things happening there? And then the thing we have to bring in is this finding of a pronator drift, which is a very good finding to suggest that there is an upper motor neuron lesion happening, in addition to these sensory things that we, in addition to these sensory findings that we have, which suggest a peripheral neuropathy. And so, I would say the question then becomes: are there categories of disease that can cross both into the peripheral and into the central nervous system? And Aaron Berkowitz taught me that yes, there are, and they are oftentimes paraneoplastic mediated neurologic processes or neurologic complications of cancer. What those are, I'll be honest with you, I do not have a well-developed list of those that I could rattle off the way that a neurologist like Aaron does. But I think that is one thing that potentially comes to mind. But we also have to be open to the fact that there is actually multifocal motor weakness from a upper motor neuron process, potentially a cortical disease or a spinal cord disease, and that the neuropathy is just a bystander and something that's been going on for quite some time. So I don't know where to shine the spotlight right now on the neurologic process with any real degree of certainty. And so that's why I'm also struggling with this. That's not to mention that we then have these musculoskeletal findings as well, right? And so the question is this a disease process, right? Before going there, I will say, we see signs of a potential inflammatory arthritis on exam. Why do I say inflammatory? Well, we see pain with range of motion. We see an effusion in the bilateral knee joints, and we see some erythema. So we're seeing findings that the knee joint in and of itself is inflamed. Is this a primary, is this a disease process that primarily impacts the systemic body systems like the musculoskeletal system that we're now seeing neurologic complications of? Or is this a neurologic disease that has some musculoskeletal complications? The odds are that it's the former, because it's most neurologic diseases will be isolated to the nervous system themselves, whereas many systemic diseases can then make their way into the nervous system. So how do we start to link these together? Well, there are a number of inflammatory arthritides that can have CNS manifestations, the most common of them being something like rheumatoid arthritis that can have things like a CNS vasculitis. You can get a number of other CNS complications of RA. We can also have a systemic vasculitis that has also impacting the nervous system. That can have musculoskeletal manifestations that then also have CNS findings as well. That could cause these upper motor neuron findings that we're seeing here. You can also have endovascular infections that make their way into the joints and up into the brain. Something like endocarditis could be leading somebody to send septic emboli into the brain that could give us motor weakness, and also sending embolic infectious phenomena into the patient's joint. I will say that I'm not sure that this joint exam is quite consistent with septic arthritis, because it seems like there is some, or at least a good amount of range of motion. It's maybe not like a fixed joint that the patient is unable to range at all. So where I'm sort of at now is it seems like we're dealing with an inflammatory arthritic disease, and one that can also move its way into the CNS. But how we're going to make progress on that is really going to depend on two things. One, what more data can we gather about what's happening within the joints themselves? And what more data can we gather about what's happening within the nervous system? I think our highest yield for the central nervous system right now is going to be a brain MRI, because we have this finding of pronator drift that we see, and seeing is there a cortical lesion that we can potentially isolate that can explain, or a spinal cord lesion that we can see that could potentially explain this patient's findings. And then in the joint world, we might be looking at an arthrocentesis or further imaging of the joints to get a sense of what's happening there. But that's about all I feel comfortable saying at this point of the case, because again, I'm having a really hard time piecing all of this together.
Yeah, and don't worry. The final diagnosis of this case was also one that sort of kind of was a little bit wild. So labs, and I'll go into the labs first because I think you requested an MRI. The MRI ultimately reveals the final diagnosis. So let's do labs first. White count of 7.8, hemoglobin of 14.1, and platelets of 185. And the differential on that white count was normal. It was like 63% neutrophils, 22% lymphocytes. As for his CMP, sodium of 142, potassium of 5, chloride of 111, bicarb of 19, BUN of 46, a creatinine of 3.36, a glucose of 79, but we did get an A1C later, and that A1C was 7.3. His liver functions were normal. I think the only thing was like a low total protein at like 5.9, but that's pretty much it. We did get a lipid panel on him, and the lipid panel showed elevated triglycerides, elevated LDL, and low HDL. But the cholesterol was within normal limits. And then on CT scan, there was no acute intracranial process. This was a CT brain without contrast. But there was some mild chronic small vessel ischemic changes and a remote left parietal infarct that was seen. We did ultimately pursue an MRI, however, and that will be the final aliquot, and that will reveal the final diagnosis.
Well, I think the fact that we are looking for the MRI definitely is going to point to that the neurological exams are, the neurological symptoms were the spot that we were going to with a good direction. We have to focus on the neurological exams and put the knee pain kind of away. thought that I have been thinking about, and I put it in the chat, is that this patient has nicturia, incomplete bladder, empty, constipation. He's a male, old. Something that crossed to my mind was a prostate cancer with metastasis in the central nervous system that can cause all the findings. Although the CT with no intracranial process, I'm not quite sure if it's going to rule out that 100%. Or the prostate thing also fit with increased creatinine, and it would make the gabapentin, it would need adjustment of dose if this is kind of that is going on for a couple of weeks, that increase the neurological symptoms. Although we have to distinguish if this creatinine is acute or if there is some kind of kidney damage because of the diabetes, new onset diabetes for, I don't know, 10 years. They say that it wasn't, he didn't went to a doctor, so maybe there are underlying CKD. He also had all the risk factors for having any new stroke in the cerebellum that could also explain all the dizziness. The pronator drift could possibly fit in that diagnosis. Beside of that, I think, and all the autoimmune ALS kind of picture. I don't think I could add any more beside that.
Margo, I think that I honestly have nothing to add to what you just said here. I would say we have some interesting lab findings here, but I'm not sure how much diagnostic weight they carry at this point in the case, right? Somebody who has been having falls at home, it sounds like difficulty taking care of himself, could certainly have an acute kidney injury like this from a pre-renal AKI. This could also, again, be the sign of potentially something like a glomerulonephritis if we're dealing with an underlying vasculitis, but we would probably be seeing something like findings of an active urine sediment like proteinuria, hematuria, potentially dysmorphic RBCs, which we don't have information about here. So I would say I am struggling to know what to make of some of these lab findings in terms of how much of these are signal versus how much of these are noise, particularly in the presence of knowing that there is probably going to be something on the MRI that we can make hopefully a pretty definitive diagnosis of. And so at this point in time, I still think I'm sort of stuck on that this seems to be either a primary neurologic disease process, or sorry, I should say that this is potentially a multisystemic disease that involves the neurologic system, many of which we have already listed, or this is potentially actually just a primary neurologic disease process, and that these joint findings that we're seeing, I think as some people have mentioned in the chat, are just a complication of the fall, and that actually the knee pain is just from the patient falling at home over time. I think until we have, or in the absence of a definitive neurologic diagnosis, I think we have to take those knee findings seriously. But if this ends up being a case that centers on an underlying neurologic disease process, then we can probably piece together everything else outside of the nervous system as being a complication from that finding. So I'm excited to see what the MRI shows. If we go through the cognitive exercise and say what types of things can we make a definitive diagnosis of, or I should say, what kinds of nervous system or what kinds of neurologic diseases can we definitively diagnose via an MRI? The list is actually not that long, right? There are some things that have characteristic findings like multiple sclerosis or PML, progressive multifocal leukoencephalopathy, but this patient doesn't necessarily fit the demographic factors for either of those. We can sometimes see a mass on brain MRI, whether it's a ring-enhancing lesion or a brain mass. But even then, the diagnosis oftentimes requires further sampling because we are left with, is this mass an infection, like an abscess, or is it an underlying cancer or something, right? And that oftentimes can require prominent tissue sampling. There are some tumors that we can diagnose just based off of imaging alone, but I won't pretend like I'm I'm somebody who can do that. So oftentimes it will be a multidisciplinary discussion here. But the fact that the brain MRI reveals the diagnosis here is something that I'm actually very intrigued about because it can be challenging to make a definitive diagnosis using MRI alone for neurologic disease processes, unless we get things like an LP or a biopsy to sort of further qualify it. So I'm going to turn it back over to you, Drew, to sort of bring us home here. But I'm excited to learn more about this because this has been a really fun one to think through, and also one that has left me feeling like a final diagnosis is quite elusive.
All right. Okay, I lied. there are actually 3 things that'll reveal multiple final diagnoses. His knee pain actually was osteoarthritis. The x-ray that was done when he was in the ED showed evidence of joint space narrowing and osteophytes in the joints for both knees, actually. So that knee pain was still, was still there, and it hadn't gone away. As for his confusion and just general not feeling right, there was an ultrasound done of the kidneys, and it revealed hydronephrosis in both, and it also revealed bladder distension, as the patient was unable to void. And finally, the MRI brain. This was done without contrast. A small focus of an acute infarct in the left pontomedullary junction. So this patient had 3 things. He ultimately had hydronephrosis of his kidneys due to an obstructive uropathy due to benign prostatic hyperplasia, which we ultimately treated by decompressing the bladder, putting in a Foley, and putting him on Flomax. He had osteoarthritis, which we'll be treating later on outpatient. But his brain MRI revealed a final diagnosis of a left pontomedullary stroke, in addition to the old left parietal stroke that was already there and that he had most likely had already recovered from. So just to give you an idea about this patient, he was ultimately put on secondary prevention, eventually had to go to rehab, and actually just recently got out of rehab. So just going to say here that this was a patient that I saw like in my very first week of intern year. So this is a memorable one.
Drew, what do you guys think about his peripheral neuropathy? I mean, that still is not kind of fitting with this.
A1C of 7.3. It's likely due to diabetes, and he's on metformin right now. The other thing too was that the ED put him on gabapentin, even though, and I guess I should have noted this earlier, in the ED, the creatinine was about like 2.9 or so. So at that point, our team was basically thinking, why in the world did the ED put him on gabapentin when they knew that his kidneys were not working right? So, yeah, that's basically this case.
Very interesting case. It's humbling for a number of reasons. I think one is just the reminder that multiple different disease, or that Occam's razors, that we enjoy, but then there's also Hickham's dictum, which is that the patient can have as many diagnoses as they please. And I think that this is a great example of a number of common diagnoses coming together to explain a pretty complex clinical syndrome. I'm curious, Colleen, Franco, any reflections from you all before we turn it over to Rafa for the teaching points here?
I think I will first. Don't frame the patient. For me, that's the best thing I can take for this, because something that we can easily put that regarding his age or regarding some common symptoms, we can also have an acute process on this patient. So the fact that he came with knee pain, and I think the decision to make him going from the outpatient to the inpatient was the best. I think for me, it's not framing the patient.
I think, we've had a couple of cases, maybe just one other case that I'm thinking of recently, where the neurologic exam is like not quite so clean, or like the textbook version of what you would kind of expect to see with some of these diseases. And I think it's just, for me, is a very humbling reminder of like how much information that exam kind of holds, and also how much of an expert you have to be to like really truly interpret that information. And it's just, yeah, something that I am always in awe of.
I'm with you, Colleen. I found this case to be very challenging for that specific reason of having a hard time deciding what is like how do we group these symptoms, right? If we actually rewind the case, the way that we group this is that there was 5 days of falls, and then there was basically weakness, predominantly like slightly more increase on one side than the other, and everything else in this case is actually noise, right? The left-sided stroke leading to the slightly increased right-sided weakness, and everything else was sort of not necessarily related to the final diagnosis here, right? I was like taking gigantic bites of data around joint swelling, multi-system disease process. Is there like, how do we start to ramp these things together? And then using that retrospectroscope, we can see sort of a straight line from the final diagnosis to some of the initial findings. And that I have found to be such a difficult part of the clinical reasoning process, is to sit here and say, how are we going to pick the symptoms that ultimately make their way into our final representation of this patient's problem? And I think that this was a humbling one, because it was, at least I found it really hard to decide what actually belongs in that problem representation and what are the things that are sort of bystanders here to what is like the predominant problem in this patient. So I'm with you. Like like multifocal neurologic exams that cross sides of the body and peripheral and central is an endlessly challenging process to decide what's new and what's old. And I think, yeah, this was a very heavy reminder of that, but a lot of very rich learning. And it was made much more fun getting to discuss with the two of you, Colleen and Franco. So thank you all for volunteering for the case today.
And I guess I just want to add one more thing, Jack. Sometimes the bread and butter cases are not necessarily all that bread and butter. And sometimes bread and butter cases might be more complicated than those zebra cases that, you know, are able to be presented cleanly in a virtual, you know, morning report style case presentation like this.
One more reflection that was like just kind of came to me is I wonder, had we gotten this case, and in this case admitting the ED, like how differently we would have framed problems in this case. Like if a patient, you know, like certainly like you would know in your sign out that this patient has a creatinine of 3.3, and it wasn't really something that was like considered whatsoever until like much later in the case.
Deborah, I think she froze for me. Did she freeze? Great. Okay. Well, hopefully Colleen's internet will return. But Rafa, in the meantime, why don't we turn it over to you for the teaching points?
Okay, so first, thank you, Drew, for the case. Really, really interesting, very typical one indeed. And also thank you, Colleen, and thank you, Franco, for discussing with us today. And everyone that took their time to be with us discussing and learning medicine together. So we had this patient with knee pain, and we thought about many etiologies through the lens of demographic, the context, the time course, and Jack taught us to divide that base into three buckets: the MSK, for example, meniscal tear, ACL or PCL tear, a patellar tendon tear, or osteoarthritis, especially if this is a female patient with a high VMR and higher than 50 years old, or inflammatory arthritis in the setting of infection, crystal, systemic rheumatic disease like RA and psoriatic arthritis. But then we saw that this patient, besides the knee pain, also had weakness, hand tremors, falls, and then with Jack reminded us that falls could have many etiologies. For example, the muscles, the nerves, vision, the cortex, the balance could all be affected. And then we saw that this patient had right hand weakness that could point to a neurological cause. And then when it comes to impaired speech, this is something that we always discuss on your VMR, and we have to take into consideration the time course. If it's sudden acute, we could think about a stroke, or if it's chronic, it could be a neurodegenerative disorder like AD. And then we can divide impaired speech based on aphasia, which is a language cognitive dysfunction, or dysarthria, which is a language motor component dysfunction. And then Jack taught us about, for example, thinking about tongue pathology, for example, amyloidosis, that could be affected in many systems, and also many areas above the spinal cord could be affected, leading to dysarthria, for example, the cranial nerves, the cerebellum. And then we saw that this patient had many neurological deficits, motor, sensory, and it was difficult to localize. And then we thought about, due to many neurological deficits, about systemic diseases affecting the central nervous system, for example, endocarditis with septic emboli, or a primary sinus disease like demyelinating diseases or PML, and the affected joints could actually be a consequence of falls. And then finally, we saw that this patient actually had multiple diagnoses. So we have this saying here in Brazil, I don't know if that makes sense in the US, but patients don't read textbooks. They can have as many diseases as they want. And we saw that this patient through the X-ray had joint space narrowing, and this was a sign of OA, the BPH leading to obstructive neuropathy, and finally DCT showing a stroke, which could be, we could think about stroke due to the lipid profile of this patient. So thank you, everyone. I hope to see everyone tomorrow, and hope everyone had a great time with us.
Hi, guys.